Good evening, everyone, and welcome to tonight's Woo You webinar, Refractive Surgery Overview and Complications with Dr. Leonid Zukin. Thank you so much for being here tonight. Looking forward to learning from you. Next slide. And I'm your host, Elise Kramer. So I'm going to introduce our amazing speaker. Leonid Zukin, MD, is a board-certified and fellowship-trained cataract, refractive, and corneal surgeon. Dr. Zukin is originally from Colorado. He obtained early guaranteed admission to medical school after high school via the University of Colorado's BS MD program, where he graduated summa cum laude and received the Outstanding Undergraduate Award as the top graduate from the college. Wow. He then matriculated to the University of Colorado School of Medicine, where he had an early interest in surgery and developed a passion for ophthalmology. Dr. Zukin went on to complete his residency training at the University of Southern California, USC, a perennially top-ranked ophthalmology program. With tireless dedication to his patients and exemplary clinical and surgical performance, he was selected to serve as chief resident of ophthalmology at LAC plus USC Medical Center, a level 1 trauma center with one of the busiest eye clinics in the country. He capped his training with a prestigious fellowship in cornea and refractive surgery at Harvard Medical School. Under the tutelage of global leaders in ophthalmology, Dr. Zukin obtained expertise in complex cataract surgery, refractive surgery, including LASIK, PRK, SMILE, ICL, corneal cross-linking, and all forms of corneal transplant surgery. Dr. Zukin finally returned home to Denver, Colorado in 2023 to begin practice at the Mile High Eye Institute outside of clinic. Dr. Zukin enjoys road cycling, golfing, hiking, and playing piano. Awesome. Wow. Well, I'm sure they're very lucky in Colorado to have you back with all that amazing training, and super, super excited to learn from you tonight. So I'll let you take it away, and I'll be on later for some questions.
Amazing. Thank you so much, Dr. Kramer, for that wonderful introduction. And thanks to Wu University for reaching out and inviting me to this talk. It's very an honor, and I'm very excited to be here and talk a little bit about refractive surgery. No financial disclosures. And so, yeah, just kind of a little outline of what I'll be talking about today. I'll kind of go over classification kind of scheme to think about all the different types of refractive procedures that we have available in the armamentarium, a little bit on the history of excimer technology, then go into a little bit about the different laser vision correction techniques there are, different optimizations, modern optimizations that we have in this technology, and then to kind of compare and contrast some of the different techniques that are available, review the complications, and importantly, we'll kind of review how to assess whether a patient is a good candidate for a laser vision correction or not, which I would say is at least probably half the battle in all this, to see who to pick and choose and be cautious and responsible about finding the right patient and an appropriate patient. And so refractive surgery, I think, can even more broadly be categorized in terms of corneal procedures and intraocular procedures. In terms of intraocular procedures, we're really talking about the lens or the anterior segment here, with cataract surgery or refractive lens exchange being actually an extremely powerful refractive surgery tool and technique, really. Obviously, we can correct a huge range of refractive errors with this surgery. In fact, I had a patient today in clinic that was, I believe, a +8 -3 patient. So that's really kind of beyond the limits of what we can do and what's even approved in the US for like LASIK and PRK. But that is something that we can fix with essentially cataract surgery, refractive lens exchange. Another technique in the intraocular category is phakic intraocular lenses, with kind of the most recent and most popular option being the ICL, or implantable Collamer lens. Sometimes we call it the implantable contact lens for patients. That also is something that can correct large refractive errors, more mild refractive errors without touching the cornea. Other corneal procedures within the scope of refractive surgery include incisional procedures. These are a little bit less common today. Certainly, radial keratotomy, RK, virtually obsolete. At this point, but we still certainly see patients for that that have had that in terms of evaluations for cataract surgery. It's possible for astigmatism correction to do arcuate keratotomies and limbal relaxing incisions. This little diagram shows what those might look like. The focus of today's talk really will be laser corneal procedures. There are surface procedures, the main one being PRK or photorefractive keratectomy. There's also flat-based procedures like LASIK, laser in situ keratomolysis, and SMILE or small incision lenticule extraction. I'll kind of go into more the exactly what those procedures involve, but that's obviously the focus today. For other procedures that are much less common, like conductive keratoplasty, there's also intrastromal corneal ring segments, but just including here for completion, like I mentioned, the highlighted techniques are really going to be the focus of the talk today. And also another way to classify refractive surgery techniques can be in terms of additive or subtractive techniques. Some people like to classify in this respect LASIK, PRK, SMILE being techniques that decrease the corneal thickness, phakic IOL, for example, being an additive procedure. So I would like to look at the scope of refractive error and refractive surgery in the U.S. So on the left here, we have a little pie chart. This is from a paper from a few years ago to show how, the relative proportion of folks that are myopic, hyperopic, or plano. We can see kind of a, roughly similar split there, a little bit fewer hyperos. And then on the right, I think this is an interesting chart showing how these refractive errors are treated in the US. And for the most part, it's glasses, contacts, or no treatment. And, less than 1% of refractive error actually is treated with refractive surgery. And in the case of LASIK and PRK procedures, we're looking at on the scale of about 800,000 or so procedures per year in the US. And it's a nice chart sort of demonstrating the trends over the years there, with LASIK in particular, with a peak in those early 2000s, over 1 million procedures a year. And now we're kind of in this 700,000 to 800,000 procedures per year range. And so and just want to double check that sound is okay, correct? Just want to make sure it's not breaking up or anything. Hopefully okay.
Dr. Zukin, it is breaking up slightly.
Okay. Alrighty here. Maybe I can, okay. Better now, could be a little closer to the mic there.
Actually, maybe backing away might help a little bit.
Okay. All right. A little bit better there.
It's still staticky. Are you able to unplug and replug your microphone? Are you using an external microphone?
No, it's just going through my laptop here. I can maybe log in through my phone and just use the audio there.
We could give that a go.
Okay. How's that sound?
You would just have to turn your speaker,
Yeah, I did that.
To mute your laptop. Yeah.
Got it. Did it. How better sound now?
Much better.
Okay. All right. Sorry about that, everyone. I appreciate your patience with the technical difficulties. All right. Well, perfect. So this is, I think, a really interesting thing in terms of
this excimer technology, the laser technology that's used to reshape the cornea with LASIK and PRK, is called the excimer laser. If you Google at some point IBM excimer laser Turkey, will be a kind of nice story on the origins of this technology. So actually, this was the excimer laser was a device that was being explored as I think initially by IBM researchers to look at different ways to create their computer chips. But they found that this technology is very kind of precise, does not damage surrounding areas, and wondered if this can be used for biological or medical applications. And actually, in November, around Thanksgiving of '81, IBM researchers, one of the first sort of organic tissues to be lasered with the excimer laser was a piece of leftover turkey from Thanksgiving, which is, I'll be honest, I don't know if this is definitely a true story, but I got this off the IBM website and I've heard it before, so must be the case there. But really, in this photo on the right here is a hair of one of the IBM researchers, as far as I understand, that they were able to laser in very, very precisely the letters IBM all over the hair there without destroying it. So what's the point here? That this is a laser technology that is very precise, hits just the tissue and just the area that is desired, and doesn't alter tissue or doesn't go deeper than it's intended, does not damage surrounding tissue. And PRK and LASIK were the kind of the first procedures approved here, PRK 95, LASIK in 99. Right. Okay, perfect. And so here's my schematic of a cornea, just to describe what is actually done during, and I'll start with LASIK and PRK and move on to SMILE towards the end of the talk. Here's my schematic of a cornea. The epithelium of the cornea comprises about the top 50 microns of the cornea. The rest of the cornea, we'll just say, is the stroma there. With PRK, essentially just the corneal epithelium is removed. Those top 50 microns worth of corneal epithelium is removed. I think the most common technique to achieve this nowadays is to use an solution of alcohol that loosens the epithelium, and then that can be debrided or removed. And then the laser, in my schematic here with these little thunderbolts, is then applied to that exposed corneal stromal bed to reshape the cornea. Here I have a video. This is not my video. This is from the University of Utah, showing what this actually looks like. It is a bit sped up. Alcohol's there applied to the cornea inside that little circular well. That loosens the epithelium so that it can be debrided off or removed there. So that's just that top epithelial layer of the cornea removed. That exposes the underlying stromal bed of the cornea there. And we're about to see the excimer laser here applied. And there you can see a change in kind of the light reflection. That's literally the corneal tissue being kind of destroyed there and ablated to flatten the cornea. And after that, this little sponge with mitomycin, an anti-fibrotic agent, is applied to prevent scarring, and then a bandage contact lens is placed. Over the course of about a week or so, usually over several days, the corneal epithelium will heal over that, and then the bandage contact lens can be removed. In LASIK, or laser in situ keratomileusis, a slightly different technique is employed. Nowadays, a different type of laser called the femtosecond laser is applied to the cornea to create a flap. So here's an example of that. That flap is thicker than the 50 microns of the epithelium. It's usually in the 100, 110 typically range, 110 roughly microns. So that flap includes the epithelium. A little bit of the superficial stroma is exposed when we shift that flap, and then the laser is applied to that stromal bed, and then the flap replaced. No epithelium needs to heal. Much faster recovery here with LASIK. But as you can already notice, we're lasering and altering things a little deeper into the cornea with LASIK. Here's a video of that. This is a little suction ring that gets applied to the eye for the femtosecond laser. This is the femtosecond laser docking to the eye. It's flattening the cornea there, applanating. And now you'll see the actual flap being made. This is sped up, but that's the flap being made. That opacification is a little air layer. That's these cavitation bubbles that are being made. After that, the cornea is marked here, so we can replace the flap precisely. The flap is sort of unzipped here with a tool. That's about 100, probably microns thick there, separating that flap all around 360, and the flap can be flipped over, exposing that stromal bed. The same exact laser as PRK is applied there to the stromal bed there, reshaping the cornea. And then the flap is put back down. We usually wash out that little interface to prevent inflammation, infection. And that's a little sped up version of LASIK. Again, this is not my video. This is from University of Utah. They have a nice educational YouTube channel and website there that I borrowed that video there from. And so what is actually being how is the tissue being ablated? And I will mention when the excimer laser is applied to the corneal stroma there, it is literally the laser is breaking up the chemical bonds within the corneal tissue. It is not burning anything, but it's really breaking those chemical bonds sort of, really it is sort of destroying the tissue there, but extremely precisely in the exact intended areas. I will say also sometimes patients will mention that or will ask, are you burning my eye, burning my cornea? There's no burning. There's no heat generation during this. And sometimes patients will say that they maybe had during the procedure could smell like a burning type smell, but that's not actually anything burning. It's that ablation process, and actually some of the gases that are used to produce the laser within the laser machine can produce a kind of smell that smells like burning, but nothing's really burning. And so what is that excimer laser? What is it actually doing? So these are our little ablation profile kind of diagrams that I made here with the green, yellow colors representing less tissue being ablated or less tissue being kind of destroyed. The purple and red colors demonstrating more tissue, greater thickness of tissue being removed or ablated. So with a myopic treatment, if someone is myopic, obviously the focus point of that system is in front, the optical system is in front of the retina, meaning that the cornea in that scenario is maybe too powerful for that eye. So we need to decrease the strength in the cornea, flatten the cornea. And so that is what that ablation profile looks like here on the left side. The center of the cornea is thinned out, more, and it's thinned out less towards the periphery of that ablation zone. And so that decreases the curvature of the cornea, decreases the power of the cornea, building in a minus prescription there. On the bottom, I have what would be the cross section of that type of cornea. For example, the dotted line would be the cornea before the ablation, the blue filled in cornea after the ablation. Hyperopia, sort of the opposite. We're trying to steepen that central cornea. So we're thinning the periphery more, and that will and thinning the center less. So thinning the periphery will kind of steepen that central cornea, make it more curved, increase the power of the cornea, build in a plus prescription there. Astigmatism, kind of you can imagine more of this sort of oval type shape. A key thing I do want to mention that I actually, to be honest with you, did not realize until sometime into residency and into training actually, is the fact that the laser will build these exact ablation profiles into the cornea, meaning that if there are other extra lumps and bumps on the cornea, those are not in the standard treatment profile. Those extra lumps and bumps are not necessarily going to be smoothened out. So the laser is not going to create, go from a lumpy, bumpy cornea to a perfect, perfectly modified cornea. It will build in this exact sort of ablation profile, even on top of extra little hills and valleys in a standard sort of treatment. I think you don't need to memorize certainly these formulas. The Munnerlin formula is a very sort of fundamental little mental math that we often do for LASIK, PRK, even SMILE, where the question is how much tissue is actually being removed by the laser per diopter of treatment. And the Munderland formula describes that for us. The thickness of the tissue ablated is equal to the square of the optical zone that we're treating, multiplied by the diopters being treated, divided by 3. A typical optical zone for these treatments is about 6.5 millimeter optical zone. And with that, we're talking basically about 14 microns worth of corneal tissue or stroma is thinned or eliminated to treat 1 diopter. So that's kind of a little rule of thumb that's good to know. And so what does a cornea look like after a LASIK or a PRK? Potentially, even SMILE will look not quite exactly the same, but similar. In this case, this is after a myopic ablation. There's the ablation profile, same picture as before on the right side. And these are a pentacam scan on the left and placido disc topography scan there in the very middle of the slide. So we can see the center is flatter. The Ks or the keratometry there is in like high 38, 39 range. And on the periphery of the edge of that ablation profile, it's a little bit steeper, not as flattened, 41, 42. So that's a pretty typical classic corneal contour after a myopic ablation. Hyperopic treatment, kind of the opposite there. We can see the center is steeper and the periphery is flatter. 48-ish Ks in the middle, maybe decreasing to 44, 42 off to the periphery there. I think that's nice to be able to recognize those if needed. Usually, oftentimes I have patients come for, let's say, cataract evaluation that have had LASIK 10, 20 years ago. They don't remember what their prescription was, what kind of treatment they had. Maybe some of the effect wore off, and it's maybe tough to tell just from the topography or the tomography what the type of treatment was. Another piece of data that can be used is actually the ratio of the curvature of the anterior to the posterior cornea. And this is one other way to, if one has access to corneal tomography, to be able to determine what kind of or what is likely the type of ablation a patient had before. So in a myopic treatment, for example, the anterior cornea is going to be altered, but not the posterior. So posterior stays stable. The anterior in a myopic ablation will be flattened, meaning a flatter cornea means the radius of curvature is greater. So, right, like the Earth is very flat relative to a golf ball. The radius of the Earth is very large compared to the radius of a golf ball. So flattening means larger radius of curvature. So this ratio would be decreased in the case of a myopic ablation. A typical posterior to anterior radius of curvature is about 83%. In a myopic eye that's had a significant myopic ablation, typically it'll be less than 83%. The opposite situation is true with hyperopic, with greater than 83%. This is sometimes referred to as the Goldstrand ratio. I think it's nice. Again, another little rule of thumb, napkin math type thing, if you will, to determine what type of ablation a patient may have had in the past. And so another thing that I think is important that I want to review is with modern laser vision correction technologies, what are some of these modern optimizations to really make this, it's a very popular, very successful procedure. And why is that? It's because of a lot of these modern optimizations as well. These machines, typically, in particular for the case of LASIK and PRK, there are pupil tracking technologies with the excimer laser that even if the eye kind of moves a little bit, there's a pupil tracker to adjust for small eye movements. There's iris registration to adjust for cyclotorsion of the eye when the patients are supine. But I think some really cool optimizations, more modern optimizations of these laser treatments are to optimize for higher order aberrations. So certainly we know with lower order aberrations like hyperopia, myopia, astigmatism, in addition to correcting that, we can also correct some higher order aberrations. And so the terminology actually differs a bit for what different companies and laser platforms call this. I will say I'm most familiar, I've had the most experience with the Alcon platform for this. Their terminology for this is wavefront optimized treatment. You can imagine if we're doing, for example, a myopic ablation, we're flattening the center, that could potentially steepen the cornea in the periphery at the edge of the treatment. That would induce a spherical aberration if the periphery is more curved, more powerful than the center. And so there are optimizations to the treatment profile to kind of smooth out that treatment profile to not induce extra spherical aberration during the treatment. And this is a nice sort of diagram of how they can, there's optimizations to ensure that that's the case here. Another really cool, I think, modern optimization of these laser treatments is topography guided treatments. This is something that can eliminate other higher order aberrations, including coma and trefoil, coma being the more visually significant one here. And so, like I mentioned earlier, I always thought that these, I sort of incorrectly initially thought that LASIK will complete, or PRK or SMILE, these procedures will fully sort of correct every little lump and bump on the cornea and make it a perfect sort of surface with the desired prescription. But like I showed you with those ablation profile, that's literally what is lasered into the cornea, regardless of whether there's an extra bump here or there. It doesn't adjust for that unless it is a topography guided treatment. And that can correct those extra lumps and bumps. And one of those typical patterns of lumps and bumps that can be found on corneas is this coma aberration or irregularity, where there may be an area of steepening adjacent to an area of flattening. And that can produce this comet tail sort of visual aberration. If a patient with a lot of coma was looking at a point source of light, it wouldn't be a point source. It would be like a point with a little sort of comet tail off of it. And that can obviously degrade the quality of vision there. But it is something that can, to some extent, be corrected with a topography guided ablation. Certainly, you guys can think of a type of condition that would have an area of flattening next to an area of steepening, like keratoconus. I'm not suggesting we can fix keratoconus, like someone that has keratoconus with LASIK or PRK, but folks may not have keratoconus, but may have these sort of little extra lumps and bumps that can be, at least in part, corrected. Another type of higher order aberration is this trefoil. And so, again, there are different laser platforms have different terms for this. In the case of Alcon platforms, they have this Contura topography guided treatment profile. And here's an example of some of those ablation profiles. You can see it's not exactly a myopic and astigmatic correction. It's kind of asymmetric, and it's correcting extra lumps and bumps here. So this is actually a more kind of modern optimization or treatment that is available within the context of LASIK and PRK that can correct even higher order aberrations and correct extra little kind of visually significant lumps and bumps on the cornea. And why bother with all that? I think this is kind of a nice summary slide for a lot of what I've talked about. What's the benefit of LASIK, PRK, SMILE? Obviously, the goal is to get folks out of contacts, out of glasses, and to correct their vision to, as ideal level as possible. And I think it's nice to look at the data of what is, to what extent does this happen? Is this possible? And so realistically, here on the chart on the left, this is just one study that looked at different visual outcomes essentially, and what percentage of folks achieved basically 20/20 or better with different modalities of laser vision correction. WFO, WFG, these are essentially LASIK. And SMILE here in this particular study is around this 84% range. Usually in other studies, you do see it be in that kind of low 90s along with LASIK and PRK in terms of the percentage of folks achieving 20/20 or better. So all these procedures, I think it's pretty cool, right? Like there's a procedure, a surgery that we can do that can be done where like greater than 90% of people are going to be seeing 20/20 or better. I think that is pretty powerful, something that's pretty powerful. And obviously that's why this has been for many decades such a popular and successful procedure. So it's just interesting, I think, and cool to see that in the actual numbers. And The other thing that's cool, I think, in this data is if we do these, at least, it's fairly reproducible in these studies for the topography guided treatments, where we can even push that 93% a little higher, a little closer to 100%. In this particular study, they were getting 98% of folks when they do these extra higher order aberration treatments, a few extra percent, squeeze out a few extra percent that can get 20/20 or better. Which I think is cool. Like 98%, if that's possible to get nearly 100% of people 20/20 or better with these treatments, that's pretty powerful stuff. The right side of this chart also demonstrates another one of these perks of these topography guided treatments, these modern optimizations. And that is in this, 20/20 or better, folks are, pretty comparable, greater than 90% of folks, whether we do topography guided or wavefront optimized. But in that 20/15 range, there's kind of an extra little bump, whereas maybe with a more standard wavefront optimized standard treatment, maybe 40% of folks are achieving this 2015, 2016 range. With topography guidance, at least in this particular study, folks, they were able to achieve, a little over 60%, almost 2/3 of folks were getting better than 20/20. So that's it's not like 100% of folks are getting X-ray vision here, but it's kind of a nice effect, a nice bump, a nice bonus from this modern optimization there. And so how does one sort of, like I mentioned, I'll start off with LASIK and PRK. How does one decide which one to do here between these two, similar procedures? Like I said, LASIK alters more tissue. We're talking the flap is going to be about 100, 110 microns of the cornea. We're altering something there with that flap and then lasering the stroma underneath. PRK, we're only removing the top, about 50 microns there, and then lasering. So we're saving about 50 microns worth of tissue. If someone has a very thin cornea, maybe they need a little bit bigger treatment, the PRK would be a way to salvage a little bit extra tissue, not alter as much tissue in the cornea. And that translates to a lower or virtually non-existent, almost, with PRK risk of ectasia. I'll get into that in a moment as well. With PRK, the drawback there certainly is the epithelium must regrow. That takes days, but the full recovery of the epithelium being really kind of fully smoothened out, I usually quote patients a few weeks. It can be longer than that. Often with LASIK, we're looking at, folks are 20/20 often on day one, and within a couple days, that translates to a few weeks with PRK. And the first few days can be quite uncomfortable because the patient does have a large corneal abrasion. The other thing with LASIK, we do have flap-related complications that can happen. If someone is a Muay Thai fighter or a boxer, that's their hobby, that's their passion, they have a, sort of regular, usual risk of getting hit in the eye. And if flap can get dislocated like that, maybe that's a patient that's better served with a PRK or with a SMILE procedure. So these are some of the considerations that go into this decision-making process. Ultimately, usually the end result after all is said and done with LASIK and PRK, we expect to have a similar outcome, but we can kind of have a, tailor what procedure we use based on the unique characteristics of the patient. And how do we evaluate whether someone's a good refractive or laser vision correction candidate or not? Obviously, thorough history is needed. Active, uncontrolled autoimmune disease, use of a medicine like Accutane. These can, really disrupt a good outcome with LASIK or with PRK. For example, Accutane will cause a lot of dryness of the surface of the eye. Active autoimmune disease, again, will lead to a lot of dryness, maybe potentially unstable refractions there. So we need to know all those things in the workup. Obviously, we get cycloplegic manifest refraction. We measure pupil size. We get those tomography scans like I went into. We look at pachymetry. Kind of cut off that I think a lot of refractive surgeons use is about 300 microns, meaning with the ablation, with the flap, or with anything, whatever we do, we don't want to go deeper into the cornea and sort of leave less than 300 microns of tissue unaltered. So that's sort of our threshold often. We do a dry eye evaluation, look at eye dominance. And all of this is a key thing here is if we're going to be thinning out the cornea with whether it's SMILE, LASIK, PRK, and that risks mechanically destabilizing the cornea. By that, I mean we risk potentially ectasia on the cornea. And so what do we look at? How can we risk stratify patients? Who's too high risk? Who's appropriate risk profile for these procedures? I think one of the most powerful tools here is corneal tomography or pentacam scan in this case. Here's a typical scan of a relatively healthy normal eye with a decent amount of with rural astigmatism here. So what do we look at? In the top left corner, we have essentially like a topographic map, basically, of the anterior corneal surface. And signs that maybe it's a suboptimal candidate would be inferior steepening. Obviously, that can be indicative of a earlier subclinical keratoconus type picture. Definitely want to identify that. In this case, the patient does actually have some inferior steepening. I usually use 1.5 diopters, which kind of is the case here, as a rough sort of yellow light or a little warning sign, like pay a little closer attention. We can also look at the steepness of the Ks. In this case, the patient has pretty normal Ks. If we're looking at 47, 48 as the corneal power there, that's a little on the higher end. Again, that's another little kind of yellow light, like be a little bit more cautious here, look more closely. We want to look at the corneal thickness, certainly, and where is the thinnest point. If that thinnest point of the cornea is corresponding with the point of maximal Ks on the cornea, the steepest point, that again is maybe a little warning sign. Is that maybe a little early keratoconus? Is this patient at risk for ectasia after the procedure? Another key thing is the posterior float. This, I think, is probably one of the most important things to look at, because this is where we can find the earliest signs of a keratoconus or risk of ectasia with these procedures. What is posterior float? What does that mean? In the case of the pentacam, the machine can actually calculate a best fit sphere. We're looking at the top row here. That green sphere would be, let's say, the best fit sphere for the cornea on the previous slide. That patient had astigmatism, meaning their cornea was more curved in one meridian, less curved in the other meridian. So the pentacam can actually calculate what's the best fit sphere to that cornea and see where does the patient's cornea deviate from that best fit sphere. So in the case of astigmatic pattern here, we can see the blue line there on top. That's the steeper meridian. The red line, the flatter meridian, meaning that the flatter meridian is above the best fit sphere. The steeper meridian is behind it. And so we can see that in that posterior, in that float map there, where that steep meridian, we can see minuses, negative, meaning the patient's cornea is behind the best fit sphere, more steep. The flatter meridian, the patient's cornea is above that best fit sphere with those plus values you can see along that horizontal meridian. How does that help us for identifying early or risky patients for laser vision correction? Well, if someone has a very subtle early cone, like if a cone will appear, it usually will sort of begin to appear on the posterior corneal surface. That's kind of the earliest place typically where we see the cone developing. So if we look at this, here's my representation on the bottom left there, that red outline there is a keratoconic, let's say, cornea, where there's a kind of pooching out cone there in the middle compared to the best fit sphere. That best fit sphere will really highlight any kind of subtle cone. And like I said, they usually will appear first on the posterior surface before they begin to manifest on the anterior surface. And so in this best fit sphere, we can see on that float map on the bottom right, the center plus 91. That center part is really pooching out from the best fit sphere, and then it's kind of behind the best fit sphere around that. This is a patient with overt keratoconus, but just a nice example of that. And not to get too much into this part, just a little bit in interest of time here, but there's also this enhanced ectasia display that we can always look at that really will further optimize that best fit sphere to show us subtle posterior floats. And the pentacam is a nice tool that can actually kind of collate, combine all this data into one kind of number that can be helpful and is has been shown to be statistically significant in terms of stratifying a patient's risk for post-LASIK or ectasia, essentially. And so this is a display, this Balin-Ambrosia enhanced ectasia display. Without going to every aspect of this, that can probably be a lecture onto itself. But what it does is it does calculate how much the patient's cornea can deviate from a normative database of patients in terms of the elevation change of the anterior cornea, the posterior cornea, the various areas of thick and thin areas of the cornea. How much does that deviate from normal, essentially, and how much is that thinnest point displaced? It can kind of put all these together into one composite, we'll call the bad D score or the D score, that basically has been shown to carry the statistical significance in separating normal, healthy corneas that can definitely do well with a LASIK procedure versus more abnormal corneas that are a little bit more borderline. And there's not a hard and fast rule on what the D score should be. But this is something that we always look at. If patient's D score is off the charts, maybe that's a little dicey, certainly dicey for LASIK, maybe dicey for even PRK, even though the risk of ectasia with PRK is quite low. And as a patient ages, their cornea is a little bit more mechanically strong and naturally cross-linked. So that score can be a little bit more lax as time goes on. But this is important kind of risk stratification that I always look at, a lot of folks look at to decide, should we do LASIK? Should we do PRK where the ectasia risk is less, or maybe not to do anything? There are certainly other risk stratification schemes there that folks look at, but that's a pretty popular one that's had some good data there. Other things to consider here in evaluation: if we're going to alter more than 40% of the corneal thickness, again, maybe that cornea is a little too thin. By 40%, I mean, let's say a normal cornea is, let's just say 500 microns thick. The flap is going to be about 100. If we're going to laser another 100 with that treatment, we're altering, 200 microns out of that 500 microns. That's right at the limit of what we usually consider to be safe. So that might be a situation where maybe we opt for PRK instead of a LASIK, let's say. And so that's just another sort of risk stratification technique that we use there. What is the actual risk of ectasia, meaning developing, a kind of like a keratoconus picture after LASIK that's induced by LASIK? It's pretty low. It's pretty safe. Here's a systematic review looking at how often this comes up. And you can see it's sort of individual cases, basically single or teens digits out of thousands. So it's quite rare, and more rare with PRK than with LASIK. In practice, I haven't seen or heard of someone truly developing ectasia after PRK. It's in theory possible, but very, very unlikely. So the risk of this is low, probably because we're very careful about this. But just these are some real world data on the risk of ectasia. One other thing I do want to bring up is another sort of little rule of thumb on laser vision correction. If we correct one diopter, we program the laser to correct one diopter, how much is the corneal Ks actually going to change? In the case of myopic treatments, we can expect about 0.8 diopters of flattening per diopter of treatment of myopia. Hyperopia, it's about 1-to-1. There hasn't been really strong data to suggest that there's a flatness limit. These are a couple studies, maybe probably too much text on this slide, but essentially it looked at if we're flattening the cornea to 38 diopters. Let's say you calculate, okay, we'll do this treatment for a myopic ablation. The cornea will be 38, the Ks will be 38 or 35. Is that too flat? And they found that really it doesn't degrade, it's not associated with vision loss or worsening vision at these flatter corneas. So there's not an official lower limit. Certainly one wants to be cautious if we're really approaching very flat corneas, but there hasn't been very clear-cut data on a absolute lower limit or floor there. So this, I just want to give a little example of evaluation. So here we have a pentacam scan here of a cornea. We can look at that bottom left picture. There's not inferior steepening. We have a little bit of, with the rule astigmatism here, the cornea is in the mid 500s thickness, reasonable. The flattest, the thinnest point does not correspond with the steepest point, and the posterior float map in the upper right, sorry, they're a little rearranged. There's not an obvious little cone being uncovered there. The enhanced ectasia display shows that even with enhanced highlighting of the cone, we don't have a subtle cone developing, and the D-score is normal. We can do the extra math. Okay, we're not altering more than 40%. Our residual stromal bed is more than 300. Safe to do LASIK. Here's another example of a patient that does have some inferior steepening. You can see it's steepened about to like 50 in the bottom of the cornea. On the top, we're looking 45 are the case. I'm looking at the bottom left graph there. Maybe a little thinner than the other eye. On the bottom right, the pachymetry, they're low 500s for the thinnest point. In the upper right, we can see maybe, is there a little bit of a posterior float? Okay, on the enhanced ectasia map, I'm looking at this in the center row on the right. That's that posterior float map. It is highlighting a little area of a posterior float. And yep, sure enough, we can see the D-score is really high. This is probably may not be a good LASIK or maybe not even PRK candidate with this type of cornea. So that's how we use this evaluations to evaluate essentially risk of ectasia or mechanically destabilizing the cornea with these treatments. What are other complications? Ectasia is the one that we're hyper aware of because it's something that we can prevent with proper sort of preoperative testing and proper patient selection. What are other complications? With PRK, like I mentioned, some of the short-term things, there can be pain, a little bit delayed vision recovery. Anytime we're altering the cornea, we can have infection. But with PRK, one of the things we worry a lot about is haze. That's why that video I showed you, we apply an antifibrotic agent, mitomycin, to prevent haze. If haze, and risk factors for this include for corneal haze, this is a picture of that, would be very large treatments, smaller optical zone, active autoimmune disease, exposure to radiation. Oftentimes, if this develops early in the post-op period, this can be treated and sometimes even goes away, but can be treated with topical steroids, NSAIDs. We do that anyway after surgery to prevent this haze, but can be pretty effective in the early period. There can also be late onset haze, which is a little bit tougher to treat, appears after about 3 months. This is tougher to treat with just steroids. It's a little bit more pesky, a little bit more resistant. Sometimes that requires a repeat, procedure in the form of a superficial keratectomy, maybe even a phototherapeutic keratectomy, PTK, where maybe a refractively neutral treatment is applied to ablate the scar, remove a scar tissue. Again, mitomycin is employed during the procedure to prevent this. It can be used afterwards, perhaps, to treat this. Some folks have looked at losartan drops for this as well. That's more experimental. What are some complications with LASIK? I'll be efficient here going through this. Certainly there can be flap-related issues during the procedure. These are, often it's possible if something like this happens, it's pretty uncommon with modern femtosecond laser, but this is something that can be fixed with just stopping the treatment, coming back and doing PRK later. It's also possible to have a little bit of femtosecond laser-related complications. A little actually bubbles can form because of that suction. The machine kind of suctions onto the eye. There is some pressure that's produced there, and as the laser is creating these little cavitation bubbles to make the flap, some of that gas can kind of break through into areas that are unintended. In the case of this opaque bubble layer, you can see the red arrows here. That's where that gas can kind of seep into the flap itself. That usually goes away, but it can actually interfere with the excimer laser sometimes. Gas can actually break through the flap, and there can be bubbles that make their way into the anterior chamber, getting in the way of pupil tracking. That's usually something that with a little bit of time, we can have the patient wait half hour. Usually those bubbles go away, we can resume. Other things can happen like subconjunctival hemorrhage, little epi defects. Those are typically transient. Another thing that can happen is striae. That's when the flap is not laid down perfectly flat. That can happen because we're altering the corneal shape, and that flap, when it comes back down, can have little tiny folds in there. Usually we can sometimes see microstriae. Those are usually not, partial thickness, little kind of like call them mud cracks sometimes that are usually not visually significant. Those can be observed. Macrostriae usually can be visually significant, can lead to scarring. In that case, we sometimes lift the flap and re-smooth it out. If the flap is dislocated, that is obviously a complication. That is basically an ocular emergency. It's pretty rare, but something that really needs emergent attention from a refractive surgeon to replace that flap. Other things that can be seen are diffuse lamellar keratitis, DLK. This is like a sterile inflammatory reaction that can happen. Here's some photos of different levels of DLK. Early DLK, you can see that little kind of sandy, they call it sands of Sahara, this sandy little appearance to the flap interface. That's where that inflammation is, in the flap interface. That's, like I said, sterile inflammatory response, usually very responsive early in the post-op period with topical, maybe even oral steroids. If it's unresponsive there, again, we can lift and clean, flush out that flap interface as well. Left untreated, this can cause kind of scarring and crumpling, essentially, of the flap. This can appear even within 24 hours after surgery. An infectious keratitis may kind of look like this, but oftentimes an infectious keratitis will present even outside of the flap, outside of the interface of the flap, and will usually take a few days to develop. This is something I'm sure we're all very familiar with, microbial keratitis. Obviously that looks very different and much worse than the DLK. Usually early on, and this is quite rare, in fact. I've not seen this truly in the post-op period. But early on, staph is the usual culprit. Again, lifting the flap, getting cultures, fortified antibiotics is the answer there. Later, it's usually more atypical agents. In worst case scenario, sometimes even a flap amputation is needed. Other rare type of complications, sometimes there can be a little bit of pressure-related fluid in the interface, usually self-limited if we treat the pressure. CTK is kind of an unknown cause type thing that can appear, usually painless, but can cause a hyperopic shift, regresses spontaneously. And then kind of finally here, we can have also epithelial ingrowth. That's when epithelium will grow into the flap interface. This can sometimes be not visually significant, not a problem, but sometimes it can cause scarring and kind of cause an irregular shape to the cornea because it will alter the flap contour there. This is something that can also be treated with flap lifts. Sometimes mitomycin is applied. Fibrin glue can be put sometimes at the flap edge to prevent any epithelial cells from kind of getting trapped in that interface. But certainly something we want to avoid. It's if we have to do a LASIK enhancement and relift the flap to enhance or treat a little residual refractive error, that usually increases the chance of epithelial ingrowth, usually higher after retreatments there. And I know I'm running a little low on time here, but a key thing here as well is to consider is dry eye. The rate of dry eye or chronic dry eye, meaning dry eye lasting greater than 1 year, is pretty rare with LASIK and PRK on the scale of 1 to 5%. It's usually pretty common in the early post-op period, first week, first month, and fades by 6 months, by 12 months. This is certainly possible. It is rare. And it's thought to be related to severing corneal nerves during surgery. And this is part of the reason why folks probably invented this SMILE procedure. How does SMILE work? A femtosecond laser. There's no excimer. Only the femtosecond laser makes a cut within the corneal stroma, like this, let's say. And through a small cut from the outside of the cornea, that little disc of tissue is removed. Okay. I have a little video here in the next slide. This is the femtosecond laser docking, making those cuts within the layers of the corneal stroma there, and making a little incision on the side to access that little disc of tissue. That little incision is opened up, and that little disc that's in the stroma is accessed and sort of dissected with this extra tool here, dissected from the surrounding stroma here. So you can see they're dissecting the upper part of that disc here, and then they'll flip down below to the bottom part of the disc of tissue there, of corneal stroma, and then they can flip that out. This is a little bit sped up, also not me. It's a very fun procedure, but this video here is done by the London Vision Clinic off their YouTube channel. And so what's the point here? That we're not making a huge cut in the cornea. We're not making a flap. We're not just removing epithelial tissue. Everything's done with that femtosecond laser. And so less corneal nerves are cut. There's no flap. That, in theory, will lead to less dry eye symptoms. The recovery is faster than PRK. It is a little slower than LASIK, maybe about a week to get to that. Maybe a week, a little bit more than that versus a few days with LASIK, a few weeks with PRK. The one challenge here is it does require a specialized machine. It can only be done on the VisuMax laser from Zeiss, which is an amazing laser. I've used it, works really well. The one other thing is enhancements here. If there is a little residual refractive error, become a little bit more challenging because oftentimes you may have to do a PRK on top of it. There are some techniques to kind of convert this smile to a flap-like procedure, but that's a little more challenging. The other thing is this is approved only for myopia. And the data does bear out that we have better corneal sensitivity with SMILE, less sort of dry eye symptoms have been demonstrated, more mild dryness if dryness is present there, with a similar efficacy and safety profile to LASIK. Overall, I'd say comparable results, probably a little bit better dry eye parameters, no flap. There is a nice study, and it's almost done here, the nice study here where actually they did LASIK in one eye of the same patient as they did SMILE in the other eye. So each patient in this study had LASIK in one eye, SMILE in the other. And this is a nice kind of study. On the left, they looked at visual symptoms, similar quality of vision after both procedures, similar sort of, one was not worse or better than the other in terms of any kind of halos and glare after the procedure. On the right side, this study, they looked at symptoms of dry eye. They did notice LASIK had more denervation because they're cutting more nerves. That difference between LASIK and SMILE is a little smaller at 12 months. So maybe some recovery there. And folks, at least in this study, had pretty similar. And I think it's a nice study because it's the same person with two different procedures and two different eyes. They can really compare well. They found similar sort of dry eye symptoms.